All right, so we'll skip our little break and go right into Ellen. She was kind enough to sneak out of PCHIP and come over here and spend some time with us. It's unfortunate we had that conflict on the same day. Ironic that the quality-related things overlap there. But Ellen Ward, as many of you are familiar with her, but she has over 20 years of healthcare policy experience with Blue Cross Blue Shield of Michigan. Ellen has worked extensively with hospitals, physicians, provider associations, and other stakeholders to design, develop, and manage incentive programs for Blue Cross's network of participating providers, including a $200 million hospital pay-for-performance program. Ellen is currently a manager in the Blue Cross Value Partnerships Division, which collaborates with practitioners, physician organizations, and acute care hospitals across the state to improve the health care for Michigan residents. Ellen works with both hospitals and physician organizations to build the infrastructure needed for successful population-based care, which includes partnering with MiHIN to promote and facilitate data sharing across providers and improve patient outcomes. Ellen received her master's degree in the Health Services Administration from the University of Michigan in Ann Arbor. So please help me welcome Ellen Ward.
Am I the last session of the day? Okay, because I've been told nobody will cry if we run short. So, and I have to admit I'm very impressed that when Bo asked me to do it, I said, who's going to be left? It's going to be 2 o'clock, very last session. I believed after 3 days. So I'm quite impressed with your stamina for still being here. So, the other question I have is. The agenda, the topic on the agenda is not my topic, so I don't think we, tried to do a bait and switch. It was just, the timing was such that the topic went out before I did. But so what I really want to talk about is how payers can have an impact on health information exchange, and of course I'll be using my own experiences, which is with Blue Cross. So just a show of hands, how many people here are associated with a hospital or a hospital system? Okay, just a couple. How about provider organization or practice, physician organization? Okay, and I'm assuming the rest of you are some combination of HIE organizations of some sort. Okay. Well, so as Bo said, I'm part of our value partnerships area in Blue Cross, and this is really all about value partnerships is about using our reimbursement and our provider incentives to transform how healthcare delivery is provided. And HIE fits just squarely in that bucket. It's really trying to change the way practices care for their patients, how different organizations work together, et cetera. So I think we're really lucky that we have an organization like MiHIN. We've, under the leadership of our senior medical director, Dr. Tom Simmer, we've made this commitment to building out a statewide model that works for everyone. And one of the value partnerships tenets is that the work we do is across all payers. So even though, yes, Blue Cross, we want to benefit from it, we want to do well under the incentives and initiatives that we put out there. The value partnerships creed is all about improving care across all patients, all payers. So this is just a little bit. I didn't realize how difficult it would be to actually read it. It was just kind of like where we've been, where we are now. And we started about 5 years ago partnering with MiHIN. And our first obstacle was all the legal concerns and the HIPAA concerns, focusing right on the hospitals. They didn't think, is it safe to share our data? If we send it to MiHIN, it's just out there. Who knows where it's going to go? We can't control it, et cetera. So we spent quite a bit of time working through that with all the hospital systems, making them comfortable, or as comfortable as we could, with what data sharing was all about, and that under the MiHIN model, there's this chain of trust, and that it really is okay to share your data, through the statewide service. We then moved on to, okay, now that we've got people, willing to do that, just send the data, start sending the data. And we started with ADT data. And, so the hospitals did, they sent the data, and we quickly realized, oh, we got a big pile of messy data, and all the hospitals are doing it differently, but they're sending it, so it was a start. So we quickly moved on to, and again, using our Blue Cross incentives, working with the hospital, say, okay, now we need to get some conformance around the data, and improving the data quality. And now we're kind of where that blue flag is right now, where there's been a dramatic increase in the quality of the data over the last few years, much more usable. We've moved on to some other use cases. The last couple of years, we've been giving hospitals an incentive to also send those CCDAs upon discharge. We've been working with provider organizations trying to support their efforts in receiving and using the data. Just as an aside, on the incentives on the hospitals are all about getting them to send the data and improve the data. The incentives on the physician organization side, they know they want the data. They're pretty excited to get the data, but they've needed support, and we've used our incentives to support them. And how do they bring it in? How do they put it into their workflows and make it usable? But now we're at this blue flag where we want to start talking about interoperability and bringing the physician organizations and the hospitals more closely together to say, all right, this data is flowing. What does it look like? Is it helpful? What's not? What needs to be improved? Where do we go from there? So I think we're on a kind of exciting precipice that way. So a little bit about the scope of the incentives on the hospital side. It's been about $20 million in aggregate across the state that we pay out. We focused, like I said, on ADT initially, then we moved on to the MedRec or the CCDAs and the Common Key. I think we're still working on the Common Key. Hopefully by the end of this year, it'll be more widely adopted, and statewide labs. Data conformance has been a big issue or a big focus for the last couple of years. And in 2019, we really want to start focusing really heavily on the clinical data or the clinical quality of that data. We also have skilled nursing facilities. Our footprint here is not that big, mostly because the Blue Cross commercial population just doesn't have a lot of skilled nursing facility experience. But we did, in 2016, I believe, introduced an incentive around skilled nursing facilities and at least sending their ADTs so that the physicians on the other end know when their patients are being admitted or discharged from a SNF. The physician incentives, and I want to introduce Sharon Kim, who's sitting back there, because she's kind of the brains behind our physician incentives. It's a little bit smaller payment-wise. It's $5 million annually, about. We focused on initially trying to support the providers, the physician organizations, to get their ACRES files together. Does everyone here know? I don't want to use terms that people aren't familiar with them, but their patient lists together to send to MiHIN so they know how to match the information and send it out. Then we moved on to, okay, we've got ACRES going, let's focus on using that data, the ADT data that's coming back in for your care processes and building it into your workflows. We just this past, 12 to 18 months maybe introduced, okay, MedRecs are starting to come through. Are you getting them? What are you seeing? Are you able to build those into your workflows? How do you bring them in-house? Where do you store them? All that kind of, those questions. And then going forward, focusing again on the interoperability. And like I said, I think this is where it's going to get really interesting. So let me think. So this is just a little bit of what we think our impact has been by bringing together a big payer with an organization like MiHIN. We've got 100 large and medium size hospitals. So that's pretty much all the large and medium hospitals, plus a smattering of small rural hospitals. We're gonna start focusing on them, or they have an incentive this year as well, so we hope to up that number to, there's 44, I think, in the state total of the small rural hospitals. SNFs, 206 out of maybe 450 SNFs in the state are sending ADT. Physician organizations, 39 out of 40, is it 42 or 43? 41 physician organizations are sending, and that represents 811 PCP practices. So that's all on the ADT. You can see the numbers for the MedRec or the CCDAs. A little, we haven't been at it as long. I think they're a little bit harder, but we're getting there. So the Blue Cross Vendor Initiative. Now that we've spent these 5 years getting people accustomed to the idea of sending information into MiHIN, and they're working on data quality. That'll be an ongoing process, I think, for quite a while. We want to use our incentives to really do something, I guess, more broad across the state. So with our physician practices, we'd been giving, this physician organization some money to send in acres and do ADT, and this physician organization some money, and you can get so far with that, but we more and more, we're hitting up against what are the vendors able to do and willing to do. And if each of those 41 individual physician organizations approach a vendor, they can't generally get their attention or priority. Or the vendor will tell them, sure, we'll do this. It's going to cost a lot of money, though, because it's, we're just doing it for you, or we're just doing it for you, and it's going to cost a lot of money. So we decided, well, instead of giving the money to 41 different organizations, hoping that they can have some impact with the vendor, how about if we pull all that money together across those 41, and we as Blue Cross will use our leverage and that incentive money to say, okay, vendor, whoever, please, here are some basic capabilities that we want all our PCHIP practices to have access to. So if you will implement them across all of the PCHIP practices, then there's a reimbursement opportunity to you from, through Blue Cross. And it really is getting their attention. Let's see, where am I here? And we'll also support the physician organizations, because even if as the vendors make these changes, there's still work to be done on the individual physician organization to make sure that they can, use the data and take it in and do what they need to do. But the real promise is using the weight and the leverage of Blue Cross to approach a vendor on a much bigger scale than what an individual physician organization could do. So this is really Sharon's brainchild, so I'm just kind of paraphrasing some of the information that she'll give me to do. But this is, basically a summary of what we're asking those vendors to do. And again, do it across all of our participating practices. Develop the code, do whatever it is you need to do, and implement it across all the practices. And it becomes worth their while then. We certainly got their attention. I think there's, these are the vendors that we're engaged in right now. We purposely left, there's a few in there that we've crossed out because we have approached them and they've either chosen not to engage or they've quoted prices that are just, we don't think are reasonable. But we picked these vendors because they impact, the highest impact for our providers. When we look across our 41 physician organizations, there's actually like 100 different EMR vendors. Some of them are very tiny, very local. We're trying to get as much impact as we can, as soon as we can. And we've also told them, another thing that's gotten their attention is we've told them, and we're gonna let our participating providers know who's got these capabilities in place, so that if they're out there shopping for a new EMR vendor, we're not telling them they have to use that EMR vendor, but here's a piece of information that might be useful to them, because we do expect these these providers to be participating in HIE, and some vendors will make it easier than other vendors to do that. Yep, and that's my last slide. So I told you I'd make it quick. So but anyway, it's really all about, I think we're in a good position that we do have in Michigan, is another show of hands. Are most people here from Michigan, or are you from, is anyone who's not from Michigan? Maybe that's okay, all right. So for those of you who are from Michigan, we do have, let's take advantage of the fact that we do have a dominant commercial payer in the state. We do have this value partnerships program with this approach of trying to transform the delivery of care and, across all payers, or across all patients, not just our Blue Cross members. And we do have the MiHIN model, the statewide model, which is very important to us because we don't want to just help the Epic community or just the Allscripts community or whoever it might be. We want to put in place solutions that are scalable and accessible to anyone who wants to engage in them. So, does anybody have any questions?
Is there a reason why you have discontinued discussions with those two?
Yeah, so those are the two that either chose not to engage at this point. We're hoping they'll change their mind, but we did want to highlight that we have approached them, but at this point they've either we haven't been able to make this a priority for them, or they've quoted a price that's we just don't think is reasonable for what we're asking them to do. So, Helen?
I was wondering if you had thought about including the registry vendors that are prominent in the state.
Well, we do have, Sharon, let me look to you. The registry vendors. Allscripts is a registry vendor, correct? Or Wellcentive, I'm sorry, I'm thinking Wellcentive.
So we did initially, Wellcentive obviously is a dominant player in this state, and we absolutely, a lot of the practices, for example, participate with SIM, and they pull out a lot of the information that they need for acres, for example, out of the Wellcentive. So we absolutely wanted to engage with them, and we did engage with them. Unfortunately, there were some areas where they refused to budge. We were trying to be a little more flexible with them because we know there aren't an EMR vendor, and we wanted to provide our, well-standard practices, with, as much of these capabilities as possible. But we simply kind of hit a point where they didn't want to work on some of the capabilities that we thought, they could be working on, and they just chose to not participate.
Yeah.
I'm hoping, like even with the two that are off chart right now, it's our hope that once the other vendors get going and it becomes more kind of out there and our practice are using it, we're hoping that kind of market forces being what they are and practices kind of saying, hey, why aren't you participating in this? That will bring hopefully Wellcentive and Greenway and Amazing Charts back. But at this point, yeah.
Yeah, we went into this knowing that, let's pick a dozen or so, a few may drop off, but I do believe that once, so several of these were on the cusp of actually signing, of contracts being signed with them, so the work will begin this year, that once the work is completed and the physician organizations themselves will verify that, okay, this is complete and the data's come through and we can use it the way we need to, et cetera, and we start making this information available, that maybe some of these who didn't think they needed to pay attention to us might change their minds. So.
In Trinity, we do have a project to pass common key over to all centers. A little bit of progress.
Yeah. So, there's a lot going on. We were having conversations the other day about how can we do something similar for example, with Cerner on the hospital side, you know, is there some way we can, you know, leverage our collective weight, you know, to you know, have Cerner do some things that we've been struggling with, so. But the EMR vendor is really been a big barrier recently.
It's Kevin Larson from CMS. This is so exciting, and thank you guys for doing it. It's really terrific. Just want to point out that if any of you think that anyone is engaging what we call information blocking, which is by they're intentionally not sharing data, even though they have certified technology to share data and they have agreed to share data, that you can report that to the Office of National Coordinator for Health IT. And those reports, you can actually, they will file and investigate. In fact, one of the vendors you have up there got in big trouble for having certified technology that they had actually turned off one of the features and wasn't actually letting their users use it. So just to let you know that we've heard that there's a lot of concern that people are actually intentionally not sharing, and we have mechanisms, legal mechanisms, to go after that.
And we would love to have CMS join us in this venture. So Sharon can give you our cards. All right, it's a beautiful day outside. Oh.
So I don't know if you talked to Medicaid. I don't know if they're a part of this, but there's actually money. High-tech money, meaningful use money, still at Medicaid that can be used for connecting providers to HIE. And it's 90-10 matching money, and some states have done creative things like funding that matching money not from the state, but funding it from other places. And then you get a 9 times increase. And that high-tech money is actually available even to non-meaningful use eligible providers. So some states are using it to connect long-term care or behavioral health or groups that are really important to connect. It can't pay for an EHR, but it can pay for the technical and human support to get connected to HIE.
Bo, you can correct me if I'm wrong, but I think you use our incentive. I think MiHIN uses our incentives to leverage some of that high-tech money as well. So hopefully we'll talk. Well, if not, let's start. You know, so yeah. Right.
But that money will go directly to vendors or providers?
It's kind of complicated because it's called the Physician Group Incentive Program, or PCHIP, and it's a pool, and it has to be paid out to participating providers. So we have to have someone who's eligible to receive the money do this, you know, contract and pay the money out on behalf of us. So it's kind of, you know, we'll pay the money to an organization who will then pay the money to the vendors once they've completed, you know, as they've completed the work. Sharon wants to correct me on something here.
No, not correct. But I did want to add on top of that, because we do understand that whatever we implement with the vendor, right, they're going to be a downstream charge to the provider.
Right.
So we're very cognizant of that. We're making sure to negotiate that, you know, in the beginning, and ultimately, we want the providers to see the value and the capability before they start being charged for it. So wherever we can, we are including it in the contracting that we are paying for the maintenance for the providers on these capabilities for at least the first 1 or 2 years until the providers can actually see the value.
Right.